Welcome to our training on first responders in the CARE Act. We're hoping that this training can be helpful for both first responders on the ground to better understand how they can participate in the CARE Act, and also for County BH to understand how first responders can be integrated and have some ideas for how they can work together to implement the CARE Act. So let's take a look at our agenda today. We will have an overview of CARE led by my colleague, Dr. Deborah Rose, and she'll describe the purpose of CARE, including who it helps and why it's created, and also overview the CARE process and how first responders can be integrated into that. And then our second section, we'll be hearing directly from first responders in the ground. Two of these first responders are in counties that have already implemented CARE in both Stanislaus and Los Angeles counties, and we'll hear about what they've learned or recommendations they have. We'll also hear from a first responder in Fresno County, which hasn't yet implemented CARE, and think about what they've done, the groundwork they've laid in Fresno County that they plan to transition to how they implement CARE in Fresno. Some learning objectives today. Our goal is that by the end of this session, you'll better be able to understand the unique aspects of CARE, including those different pathways and how CARE participants can receive services. And also, we hope that you better understand petitioning and referrals in CARE as it pertains to first responders. And then take a look at some best practices about interacting with the CARE population, including embracing a trauma-informed approach. And we link to a number of associated trainings in our training materials. So please, as you're seeing links on the presentation today, if you want to click on those training materials in the PDF and click on those links, and you can go to different trainings that we have today. So before we jump in, I wanted to introduce our three panelists. We're excited to have Dr. Deborah Rose, my colleague at Health Management Associates, and then three first responders, Raul Dominguez, who is a former parole officer and works in Stanislaus County, and hear about a unique team that they set up to help provide coordination between first responders and County BH. Then we'll hear from Dr. Ken Katz, who works in Fresno, which has, and to hear about his background as a retired law enforcement, and he straddles both worlds of behavioral health and of first responders. And then we'll also hear from Dr. Susan Partovi, who is a practicing physician in Los Angeles County, and she works with the CARE population, so individuals living on the streets that have serious mental health conditions, and hear from her about her advice with working with this population and how to effectively approach a petition. So with that, I'll turn the time over to Dr. Rose to talk to us about the CARE process. Deborah?
Happy to do so, and I'm thrilled to be here. Thank you, Patricia, and I want to thank my colleagues for joining us today. They really will have incredible content to share, so I probably will speak very quickly, going over my slides so we can be sure to hear from them. We're going to begin by talking about CARE, an overview. We'll talk about the purpose of CARE, the CARE Act. We'll talk about who it helps and why CARE was created. We'll get into a little bit about the process, about eligibility, about petitioning, and then talk about the services that can be brought to eligible participants through the CARE agreement and the CARE plan. Let's go to the next slide, please. So let's jump into our content. Let's talk about CARE. The CARE Act creates a new pathway, a new venue to deliver behavioral health services and substance use services. It's really created for those individuals, the California residents, who are living with serious mental illness, specifically schizophrenia or psychotic disorders. And these are folks who, without treatment, tend to end up homeless, unhoused, or incarcerated. So it's really the individuals who are needing intensive services. CARE is designed to be a person-centered pathway to services. So this means that every CARE interaction is designed around each individual, their unique preferences, needs, service wishes, language, what's specific to that person that could help that individual in a path of behavioral health recovery. Services can come in different forms. It could happen through a voluntary engagement. It might happen through a care agreement or a care plan. And don't worry about those terms. I'm going to discuss them each in detail on the next slide. The care agreement and the plan, again, we'll talk about this a little bit more, are implemented by county behavioral health organizations. I'm sorry, I should say county behavioral health agencies. And interestingly about care is that behavioral health agencies run by the county are obligated to provide court-ordered care services. So this act not only essentially mandates the individual to services, but also to the county who is ensuring the delivery of care services. And again, these might include behavioral health, it could be substance use services, housing, and other kinds of community supports. Important to note that the care pathway begins when a petition is filed with the court. Let's go to the next slide, please. So the CARE Act, it's a way to connect individuals to services in their communities. There are many paths in, multiple ways to access care, and there are individualized paths out. Like I said, the goal, the overarching intention of CARE is to provide individualized services and supports to members of your community. What I'd love to do is encourage people on this call today is to think about how first responders can consider care to help an individual receive services. Patricia mentioned that we'll be providing lots of links. There are a number of links where you can learn more, care at a glance and a care process, very detailed workflow, and those links are at the bottom of your screen. Let's quickly go over eligibility, and there's a list on your screen, so I'm not going to read through these. We do have more links at the bottom, an eligibility fact sheet, and eligibility in practice and other training that we've done, along with some codes, so you can take the time to look at those in more detail later. So it's important to have eligibility in mind, but really what matters most is that the petitioner does not have to prove each element of eligibility. This is a good faith gesture. If you believe that a person may be eligible for care services, a referral can be made or a petition may be filed. So again, this isn't a test that you have to pass. As a first responder, it's likely that you've encountered the people living in your community who may be deteriorating physically or mentally. It appears that perhaps they're not stabilized in treatment, or you don't know if they are. And it's possible that care might benefit that individual. In these situations, you don't need to confirm the diagnosis or each of those factors for eligibility, but you know the person needs support. And so we certainly would encourage that if it appears that the person may benefit from care services, then a care petition may be filed. So let's talk about first responders as eligible petitioners. If nothing else, the message that I would like you to hear is that first responders are eligible petitioners. There's a list on the screen that includes things like peace officers, paramedics, homeless outreach workers. These are just an example of some. This is not an exhaustive list. There certainly are many first responders who are working with people with serious mental illness in the community. And these individuals who have made multiple outreach efforts, who are trying to engage somebody in services, in treatment, or other kinds of social community supports, these are the folks that you know and the people that you might consider as eligible care respondents or eligible care candidates. Again, there's a number of links at the bottom of your screen. There are some resources for petitioners and some other code. We encourage you at your leisure to please take a moment to look at some of those additional resources.
Since this training was originally recorded, the petition forms produced by the Judicial Council of California have been updated as of July 1st, 2025. So we wanted to just go over some of those changes and provide some general guidance about completing the petition. So the purpose of the petition, remember, is not to prove everything up front,
but to give the judge enough information to decide whether the case should move forward. Based on what's submitted, the judge may either dismiss the petition or ask the county behavioral health agency to investigate further. The petition doesn't need to be exhaustive. It should include what you know and have observed and enough to reasonably believe the person may meet the care criteria. So there are two different ways to file a petition depending on who you are and what information you have. Regardless of which option makes sense for you, the petition will ask for information about the petitioner, information about the respondent, such as how to contact them and any language or accessibility accommodation that may be useful, and information about a court referral, if applicable. The bulk of these forms will focus on capturing information related to an individual's potential eligibility. So let's talk about these two options. So the first option that you see on the top is a general petition process that would make sense for most petitioners. You would use this path if you're not a licensed behavioral health professional, for example, family members or first responders. Step one would be to fill out the Care 100 form, which lets you explain your observations in your own words. And step two would be including one of the following to support that petition. So the Care 101 form. So this would be a declaration from a licensed behavioral health professional who's either examined the individual in the last 60 days or has tried multiple times. And they must believe the person may meet the care eligibility criteria. So the other option to accompany the Care 100 form is documentation. So this would be evidence that the person has had at least 2 intensive treatment, one within the last 60 days. So this could include hospital discharge papers or a signed declaration for someone with direct knowledge of those hospitalizations. So if the person completing the petition, the Care 100 form, has direct knowledge, the declaration of the 250/250s can be included directly on the Care 100 form. Otherwise, that information can be attached to the petition, like I mentioned, a hospital discharge paperwork, a declaration from a witness, or other evidence of those 250/250s. So that's option one. Option two is a streamlined process for licensed behavioral health professionals. So you would use this path if you are a licensed behavioral health professional, which could include members from county behavioral health agency. So for this option, you would only fill out the Care 102 form. This combines both the petition and the declaration from the licensed behavioral health professional into one document. Like the Care 100 and the Care 101, this Care 102 form allows you to describe what you've observed and why you believe the person may be eligible for care. Regardless of which option you use, the key is to provide enough detail for the judge to decide whether the case should proceed, not to prove everything. If the judge believes there's a reasonable basis, they may request more information or begin the formal care process. Just document what you know and keep the focus on what you've personally seen or learned. For more information about the mandatory forms, you can see the forms on the Judicial Council website, and there's many resources on the CARE Act resources for petitioners page, including additional tutorials and information for different petitioning groups.
We'll talk a little bit about the role of the first responder. As I mentioned earlier, first responders are eligible petitioners, and a variety of first responders in various organizations and various forms can do the petition. First responder can also be a partner who makes a referral to CARE. So I'm going to talk about both of these roles. As a petitioner, when you've identified the individual who you think might benefit from services, look at the court, the county, the court system that is offering care. And we have a list of the on our website, we have a list of the counties who have already implemented care. And we'll be continuing to update our website over time, and that link is at the bottom. And there's where you can find information about each county's specific court, the behavioral health agency, and other information about care proceedings. Fill out the forms that we've just mentioned and talked about. again, to the best that you can, provide the narrative based on what you would know and what you've observed and what you've gathered. Some counties are doing it electronically. Some are using a physical copy. It really depends on your county's system. And we've said this a few times, but you don't need to know with absolute certainty the diagnosis. Document the observed behaviors. So that's the first possibility. You, the first responder, as a petitioner. The other possibility is as a referral source. And this is the idea that you are partnering with other organizations in your area. It may be, and most likely will be, your county behavioral health agency that will stand in as the petitioner. So think about what might happen in your county. And we certainly encourage the counties to talk about how they might appoint a liaison to ensure that there's shared communication. And we've heard that this is happening. I'm going to ask if we can bring in Raul to talk about his experience in Stanislaus County.
Good morning, everyone. Thank you, Deborah. Just kind of give you guys a quick overview about how care referrals are handled in Stanislaus County coming from law enforcement. So I'm a probation officer with Stanislaus County. I manage our care outreach team. We'll talk a little bit more about that later on in the presentation. But what the main goal is to have law enforcement have a connection to someone in law enforcement that kind of understands the law enforcement field and also has access to behavioral health, the behavioral health system, to kind of just give some questions to, but also give referrals. So like Dr. Partovi said earlier, you have Joe Schmo who's out in front of the liquor store, and you're getting calls for service, and you keep getting calls for service. It's taking up a lot of your time out in the community instead of being proactive. You know, you're handling these situations that may not rise to that level of needing you there. Those are the type of referrals that then are made to me as the care manager. And then I work with our behavioral health team to fill the petition, get the petition completed, and then move it down the road. So it's really beneficial for us. It's really helped us kind of build that bridge between behavioral health and law enforcement to make sure that everybody understands what their role is and how we kind of work together to make sure we're helping these individuals who are needing the help and have been in distress for many years and haven't been able to receive that help.
Thank you so much, Raul. I'm excited to hear you talk more about what's going on in your county and your role as liaison. Why don't we move on? I'm going to quickly talk about what happens after a petition is filed. First responders are replaced, as are other petitioners, by the the county behavioral health agency at the initial appearance. It is somewhat important to make an appearance. The court could dismiss the case otherwise. And what we're hearing so far is that many counties are allowing for remote appearances. Let's jump forward and talk about a couple of FAQs that we have heard. We've said it before. What if I don't know if the person is eligible? Well, you don't need to know with absolute certainty. Document what you know. Another question is, what does this mean that there are multiple pathways to services? After the petition is filed, if the individual says, yes, I'm on board and voluntarily engages in services, the petition will be dismissed. That's one possible pathway. Another comes about if the individual has not initially volunteered in services. Instead, with the court's assistance, the development of a care plan or a care agreement is developed, then their participation is voluntary in care, and they will be connected to services. And the third frequently asked question that we've been hearing in preparation for this is, well, why should I petition for somebody? I think the most important thing to consider is that a petition essentially jumpstarts this conversation about identifying the individual's needs, preferences, wants, what services he or she might benefit from. It's an acknowledgement from both the provider side, from the first responder side, and the court side that the person would benefit from services. And so this is an opportunity to flag them and to bring attention to the development of a plan or agreement to support an individual. There are, again, these multiple pathways, and they all ideally will end up in successful delivery of services. Raul, I'm so glad to see you back here. Maybe you could tell us a little bit more.
Yes, I'd like to just share a little of our experiences with care petitions. So even though a care petition has not gone into a care plan or a care agreement completely, what's happened is these individuals have received services from behavioral health just by being referred to care. So some of these individuals who maybe been in the community, been dealing with their mental health or substance use disorder issues without treatment, because either lack of transportation or just maybe even lack of willingness. We've learned is with referring them to the care court, to the care petition, that these individuals have voluntarily engaged in mental health services. And we have one really great example of an individual who was on post-release community supervision with us, who was really deteriorating in his mental health. And with after the care petition, he's voluntarily engaged in services. He's about 6 months now. He's in a boarding care. He's being taken care of. He's taking his medication and is doing really well. And due to the referral to care court, he was able to really take on those services and is really flourishing. So I think there's a lot of avenues for people once they're referred to with the care petition to take on different services. So one of the biggest things I guess I'm an advocate for law enforcement is or first responders is if you have someone who just seems like they would benefit from a care court, refer them, because there's different avenues for them to take advantage of.
Thanks, Raul. And that's a fantastic story. Multiple pathways to receiving services, and really appreciate hearing what you've done for a member of your community. Again, I'm looking forward to learning more about Stanislaw in a moment. Why don't we jump forward to talking about what's in a care agreement or a care plan? I've mentioned them each a number of times. So a high-level overview, we do want to get to our colleagues' content. The care agreement or the care plan will include member information, participant information. It'll be an outline of services, and some of these services might include intensive wraparound services like ACT or FSP. It could be other mental health services or substance use treatment services. It may include medication, housing, and a variety of other social services. A couple of high-level points is that both the individual and the county are expected to comply with this court order or with the agreement or the plan. Essentially, this is a way of ensuring that services are identified and services are provided. So it's not just a list of demands that the person has to follow. It's really services that the person has a right to receive in their county. One highlight is that the judge, again, I've mentioned the judicial broad discretion, does have the ability to prioritize certain services, housing in particular, and supports. And so there's a way of ensuring that people can get access to the services that have been identified for them. Few more links are on the bottom of your screen. We encourage you to take a look at them where you can get more details specifically about the care agreement, the care plan, and some of the codes that are associated with the statute. Let's move forward. A lot of information I'd like to share with you here. As first responders know who are on this call, they are interacting with people with serious mental illness every day. Many counties offer specialized training, and some are offering specialized training in care. That's especially helpful, as we've heard Raul describe being a liaison to law enforcement in his community. So he is the expert on all things care. Take a moment here to talking about working with folks who may be eligible for care and why that's important for first responders. The first is to really recognize the features of psychosis. I think it's, and I'll mention multiple links again here, which we'll talk about, where you can learn more about working with individuals who have schizophrenia or other psychotic disorders. But a couple of notes: being able to understand what psychosis looks like, right? It may be people are having delusions, beliefs that are false, or hallucinations, voices or other things that other people don't hear. Sometimes command hallucinations, where the voice is telling somebody what to do. We might see other symptoms like disorganized thinking, erratic behavior, paranoia, the radio is talking to me, or the TV is talking about me, or unstable emotions. There could be a number of factors that are contributing to a psychotic state. It's important to know, again, you don't need to know what those factors are, whether it's substance-induced related, something organic. It's really important to know that you can respond in a trauma-informed way, in a caring approach that's validating that person's experience, regardless of the cause. You don't need to diagnose somebody specifically for care and for care access, where you are under the belief that somebody might benefit from this connection to services. It's really important that in this process, people feel safe. And sometimes that's about validating their experience. That's really scary if the TV is talking to you. I'm sorry to hear that, as opposed to dismissing somebody's experience or judging their experience. So validating the feelings can sometimes bridge the gap and create the initial sense of trust and engagement, which I think is an essential component of providing any services in the community. We do want to talk about understanding that trauma may understandably cause distrust and fear. Many of the folks who are living with a mental health condition have had previous negative experiences as a result of their serious mental illness, perhaps with negative experiences with law enforcement, with the community. We certainly know that people who are living with a serious mental illness are more likely to be victimized and traumatized than others. And so people may have experienced traumatizing events in their community, even earlier in their life through childhood or other relationships. We know that people of color have had more negative experiences than others who are living with a mental illness. And so really thinking about a trauma-informed approach when working with individuals. So moving away from what's wrong with you into what happened to you. Asking those questions can be a foundation for building trust and for engaging somebody in the community. Certainly managing our own racial and implicit biases. We have these. It's important to acknowledge them, to recognize them so that they don't become obstacles to people receiving care in the community, and also so that they don't become barriers to recognizing individuals' preferences, their needs, their strengths. Certainly, first responders are often the gateway to deciding if somebody is down a law enforcement path versus medical. And so recognizing implicit bias in that process is really relevant. And then on your screen, it talks about a de-escalating and a humanizing approach. So really thinking about keeping folks in the community calmer, yourself in the process. It may be helpful to ask if somebody has a psychiatric advance directive. This is a document that has been created that says, if I'm not doing well, here's how I'd like to be treated. Here's what might be helpful to me. And it even can describe things like, if I'm not doing well and I decompensate, here's how I would like my rent to be paid or my pet to be taken care of. So sometimes the psychiatric advance directive can be very helpful to identifying a person's needs, goals, preferences, and how to help that person. I think that we can pause. I'm going to again point out the links that are available at the bottom of the screen, and I'm going to ask Ken if you might join me and tell us a little bit about your experience. Ken, I
You're on
think
mute,
you're on
Ken.
mute. Thank you.
Thank you. Sorry about that. Thanks, Deborah, and hi, everyone. A lot of this just comes from thinking about crisis intervention training that a lot of you probably have had. But the first and most primary thing I want to remind people of is that first responder safety comes first. Don't compromise your safety when you're doing anything on any kind of a call, whether it's a mental health call or any other kind of call. Also keep in mind that people will sense if you're trying to rush things. So the more time you can give, the better it will be. Be genuine. Be yourself, be human to human. It's obvious that you're a police officer or a firefighter or a paramedic because you have a uniform. You arrived in a vehicle. So it's okay to say, hey, I'm Ken. Tell me what's your name? How can I help you today? I think it's also important to listen and provide what I refer to as empathetic responses that imagine what it would be like to be in their shoes and then give a response based on that. And a lot of times people talk about paranoid ideas that they're being chased or someone's going to harm them. What would be an empathetic response? Well, that must be frightening or scary or difficult for you. Also, try and recognize symptoms of mental health. Deborah did a good job, I think, of outlining those. Those should inform you about how you manage the call. And then keep in mind that how someone speaks, how organized their speech is a window into how organized their thinking is. And that should also influence the way you manage the call. Try not to validate people's psychotic experiences, but also try not to invalidate their experience. Deborah talked about being trauma informed, help them feel safe. And those are the basic keys that I want to emphasize.
I appreciate that, Ken. Thank you so much. I look forward to hearing you talk more about in a moment, sharing additional experience with us. So why don't we go to the next slide, and I will encourage folks who are on this call to take a moment and think about the question of how first responders might approach petitioning and referring in your community for the care process. How might you think about initiating a care referral or a care petition? I'm going to invite our colleagues to tell us a little bit more. And Raul, can you come back and join me, please?
Yes. Hello, Deborah.
So we've got a lot of information on the screen. We'd love to hear more about your role, what you've done to implement care so far. Please share with us.
So I'll just go over a quick overview of what CARE is in Stanislaus County. So prior to the CARE Act in 2018, Stanislaus County took a really innovative approach of dealing with the unhoused population. And they created the Community Assessment, Response, and Engagement Team, which acronym is CARE. So the team, what they started dealing with is individuals who were unhoused that were getting a lot of calls for service for things such as illegal camping, trespassing, loitering, things that really didn't amount to, say, very criminal behavior. It was more low-level crimes, more quality of life type issues. So the team decided to create a team that has probation as the manager, a probation officer on the team who would be doing helping with court processes for these individuals. And then we have a public health nurse that helps with people who have medical issues, substance use disorder counselor who can help get people into treatment, and then mental health clinicians and behavioral health specialists who help people deal with their mental health. So when this was created, it was kind of a one-stop shop for individuals who were unhoused to receive services that they weren't receiving and that were keeping them from being housed or keeping them from kind of moving forward with their lives. So the CARE team started addressing these individuals and building that rapport. Rapport building is huge with the unhoused population and even with people who have untreated mental illness. Just building that rapport to let them know that you're there to help, let them know that you're there to assist them and getting them the help that they need or the help that they want. Because a lot of times, if the person doesn't want it or willing to take it on, it's going to be difficult. So that was the idea with the CARE team when it first came on. It's really built these collaborations between law enforcement and county behavioral health to be able to share information. So that's something that's really big. We talk about also the information that can be shared back and forth between law enforcement and behavioral health. The CARE team created a memorandum of understanding with the different agencies in Stanislaus County so that we can share that information and kind of have a clear understanding of our goals on where we want to help individuals. And then also we created a release of information, which allows team members to share information with each other to be able to kind of be that cross sector amongst the different county services. So what happened is as we were receiving these individuals' names from law enforcement saying, Joe Schmo is someone who's out in the community who's not receiving services, but we've had 25 calls for service to come talk to him, dealing with him in distress or some type of mental health issue, and he's deteriorating out in the community, his medical health, his mental health, substance use disorder, it's all being untreated. Those individuals were then referred to the care team, and then we would start working with them. So what we've added to that process is, as they're referred to the care team also reviews to see if there's someone that we should refer to the care court or care act now. So individuals that come through that are referred to the care team, we screen them to now send them over to behavioral health for the care act. So that's kind of how we've kind of naturally flown, or the natural flow of what the care team had established in the past to now include the care act. And it's really something, care court, it's really a tool for law enforcement to help these individuals that, for one thing, that need the help because they're out in the community in distress. They're, like you said earlier, someone's deteriorating and really, coming close to losing their lives because they have these untreated illnesses in the community, to really help them get the help that they need. And additionally, as a law enforcement officer, a lot of times, depending on the resources you have in your community, if you're going from call to call to call to call, these added calls that really do not maybe rise to the level needed a law enforcement officer there to deal with can take up a lot of time. So it's really helping these individuals to not only get them the help that they need, but also in law enforcement to kind of free up some of that time for you to be either proactive or not just going from one call to the other, and kind of identifying the barriers that are keeping these individuals from receiving the help that they're supposed to, or that they should be receiving. So that's kind of in a nutshell what the care team does and how we work to help individuals in our community, but also how it's kind of become kind of the liaison needed for care court in our community to help get these individuals the help that they need.
You mentioned an MOU, which is a big deal for shared information about potential respondents, and a collaboration between law enforcement and behavioral health. Really work together across the aisle to create this system to get people services.
Yes, and I think that's where we've seen a lot of the success, is being able to build that bridge to identify who is it that really needs to be involved in the criminal justice system and who is in the criminal justice system that does not need to be in there because it's more of a mental health issue that needs to be treated. Yeah. So being able to really identify what is the person's need and the individual's need has helped, I think, all of us, really understand not just each other's roles in the community, but how we can collaborate and work together to help people that we serve. Thank you, Deborah.
Thanks, Raul. And I'm wondering if we can turn to you to talk a little bit about how Fresno is beginning to get ready to implement CARE.
Well, first I want to remind people that most counties in the state have not implemented. We have until the end of the year to actually implement CARE. And it's great to have counties that have already done it because we can learn from them, adopt some of the models that they're using, learn from their mistakes if there are any. But I'd hope to have more information at this point prior to this call about what the workflows will be like. But I have initiated discussions with Fresno County Department of Behavioral Health regarding workflows and ideas such as asking the Department of Behavioral Health to serve, just like Raul is in the probation department, is the central point of contact for Stanislaus County. Is there an entity, possibly a Department of Behavioral Health, that could do that, where individuals, first responders, could refer someone and then they could do the petition as a possibility if the first responder isn't comfortable doing it. If we could have a central point of contact, they could track who already has a petition has been submitted, so that we're not duplicating efforts and taking time where it's not necessary. And then in Fresno County, we have mental health field clinicians working with law enforcement. We also have a mobile crisis response team. We're wanting to look at how might they become a part of this group and working with the first responders since they're already out there in the field. One of the discussions that came out of a prior Zoom call with my colleagues on the call was I was very concerned about the amount of detail that's on the petition. And I just think it's really important to remember that you want to provide as much information as you can, even if you don't have all the information, but really just describing what you're seeing. The other thing is, and one of the approaches I'm going to take with American Ambulance is we don't have a lot of time to stay on scene to do petitions, just because we have such a busy EMS system. So what I'm looking at doing is creating an informational flyer so that when we're on a call for service and there is family or friends, we could give them an informational flyer about the CARE Act so that they can learn that they are also potential petitioners. And then I've had a conversation with our local NAMI chapter, National Alliance on Mental Illness, and they've agreed if any family member or friend in Fresno County wants to do a petition, that NAMI will assist them in actually completing the petition itself. So there are just lots of things still to be looked at. Remember that we're not going to be implementing until the end of the year. So a lot of pieces are still being looked at. We've implemented other initiatives in our county. And one of the things I really like is the Department of Behavioral Health, Public Health, and all the agencies work quite well together. I'm confident we'll come up with a system, just not quite sure today what that will look like.
And
Deborah?
thank you. Yep, I'm here.
Okay.
I want to thank you, and you made a couple of really relevant points that I've jotted down, and I appreciate the most that this is not an either or. First responders may be petitioners, may partner, but also may be community educators, and I think that's a valid point. We recognize the value and the role of serving as petitioners, of serving as a referral source, and of serving as people who can partner with our community groups like NAMI and others to help educate and inform the community about the availability of care. So thank you for adding that additional road into care for us.
Sure.
I am going to move us along and ask Dr. Partovi if she can please join me and talk a little bit, and thank you again, Ken, and talk a little bit about what is going on with Los Angeles and some of the work that you have done there.
Hi, yes. So Los Angeles did start their CARE program in December. And like I said, most of the petitions have been from family members. So this is a really opportune time to remind outreach workers, first responders, that they can be petitioners as well. And, you know, some points I wanted to make was, and we've talked about this, is that you don't have to know how to diagnose schizophrenia or psychotic symptoms, you know, and just we want to kind of cast a broad net. So if you're unsure, just go ahead and refer them and just put in descriptions like I talked about earlier. And then the other thing is it doesn't have to be like a one and done. So this could be someone that you've been, you know, developing a relationship over time. That's something that outreach workers do very well, that it's not, you know, we're not like, hey, want resources? So it is building a rapport with the client and getting them to, you know, trust you. If you're like a police or fire department, you don't have the luxury of time. And so that's where I would say, find out who your outreach team is in your county. LA County has 80 outreach teams, right? Whereas Stanislaus might just have one. So, but figure it out. Some of them are called hot teams. So homeless outreach team, so that you can start working on the same people. Or you might say, hey, I keep seeing Joe Schmo outside of 7-Eleven. Can you guys, you know, attend to him and see what's going on and build that collaboration. And then the other thing I just wanted to talk about is that, and this is kind of confusing, like we're saying it's a voluntary program, but at the same time, it's geared towards people who say, nope, I don't want anything from you, right? So we want the most resistant people, with the idea that the care team can either work with them, develop a relationship with them, and eventually get them to understand, that they're there for them and that they can accept resources, or go the court direction where the intent is that the black robe saying, you are mandated to do this, or court ordered to follow with this program, but in the end, it ultimately they can just say no. So, but we still want those people so that we can be working with the most difficult ones. And so those were some of my key points.
Thank you, Dr. Partovi, and I appreciate a couple of the comments that you made, really identifying your community partners, right? Talking about the outreach team. Ken talked about NAMI and Raul as law enforcement. And so we are doing a training on cross-sector collaboration. Exactly what you're talking about is how do we work together? But then also the idea that, as you started with, it's not one and done. And for some individuals, it's that ongoing engagement and outreach to connect to services. And it may be coupled with the Black Robe effect to engage in care over time. And so really looking at services from multiple perspectives, so that folks who are potentially difficult to engage can receive these services. So thank you very much. So before I turn this back to Patricia, I would like to, as we often do, have a moment where we take a look at ideas in action. And I will ask participants on this call to ask yourself and your colleagues, if you're encountering somebody in your community who might benefit from care, what approach or approaches, as we just talked about, would you take?
I'd love to hear from Raul and Dr. Partovi. I know that care is live in your counties. And Ken, as you're preparing for care to go live in Fresno, some thoughts that you would have and what approach you would take. So Raul, do you have 30 seconds to provide your thoughts here?
Sure. I think the approach I would take, just from a first responder perspective, is to complete the petition as soon as you can, right? So like we said, you don't have to be an expert. You don't have to be a mental health clinician to know exactly what the person is going through or diagnosing them. Just finding out someone that is in distress, that needs the help, and completing the petition. And as much as you can, I think somebody brought up, at first it seems like a daunting task. I have the same issue with it, but I've learned that a lot of it is repetitive. Just get it done as much as you can and then get it submitted to the court, and really just kind of take that approach of, just submit the petition to make sure that the individual is receiving the help that they need.
Thanks, Raul. Dr. Partovi, do you have any advice, or I know you just went over what you would recommend, but some last minute or last thoughts on how you could approach getting people connected to the care they need?
Yeah, like what you can do is, as you're talking to the client, you don't want to say, hey, I want to refer you to this court mandated program. Like you can start talking to them about, like, hey, there is a program that gives you resources. And even if they say, I don't want that, you can say, okay, well, what do you want? What do you need? And, work with them as from that angle. And then, you can fill out the petition. Just know that sometimes, as the petitioner, you might not know what the outcome is. So that can be a little frustrating, but definitely go ahead and fill it out and see what happens.
You. Ken, what about you?
Well, we don't have a system in place yet, and I think this call is awesome in terms of getting our juices flowing about what our system might look like. And I think it'll take more discussions in our group to sort this out for Fresno County. But I really want to emphasize that even though we may develop a system for Fresno County, it doesn't mean that any one agency can't develop their own workflow. So I can see the Fresno Police Department has a crisis intervention team. They may be the best entity within the department to manage petitions, or the homeless task force, things like that. So we're going to work together to develop a system. Not sure what it's going to look like yet, but we'll communicate it to everybody. And again, though, doesn't mean that any agency can't develop their own workflow separate from whatever the larger system might do.
Yeah, and that's a great point, Ken. There are a few counties who have implemented, and they were the cohort one that we're going to work out the kinks and we can learn from them. So what we are hearing is some counties are setting up a referral process. Like Raul said, a liaison that's really working with law enforcement and county BH to get those referrals. And it can be really responsive to the needs in the county and the first responders and how that works. So yeah, I think that's a great path forward for Fresno and can look different in different counties. Well, thanks to the panelists for sharing their thoughts about what they're thinking about and how to connect people to services. Hopefully this is the beginning of the conversation. You've seen resources, had some ideas like Ken said about how it could work, or some lessons learned from Raul and Dr. Partovi about how it can work more smoothly, and getting these folks the resources. So again, some of the learning objectives that we were teaching to today. The goal is that by the end of the session, you have a better ability to understand the unique aspects of care, understand petitioning and referral in regards to the first responder, and have some idea about best practices with interacting with the care population. We wanted to highlight a few resources for you as well. So we just wanted to reflect again on the objectives that we hope to achieve today. The goal that was by the end of the session, participants have an increased ability to understand unique aspects of care, including some different pathways to receiving support. And then also understand how the first responders could participate in petitioning or as a referral source. And then have an idea of some best practices when interacting with the care population, like we heard about earlier, with taking a trauma-informed approach. Let's discuss a few next steps for you. All of our trainings and resources that we've linked to today, and I'll go over a few in the next few slides, are available on our website. So you can go here to see the trainings and resources that we've provided, a volunteer supporter toolkit, a family resource guide, and you can search the libraries by your population type. So you can type in, I am a petitioner, or I am a family member, and see resources that are tagged for you. You can also join our communication listserv if you're interested in continuing to receive updates and notifications on trainings that are coming up, or materials as we release them. You can also, like I said, review available trainings and materials. We just wanted to highlight a few that we think would be a good place to start for first responders. The first one is more information about schizophrenia spectrum disorders. We have two series that might be relevant for you, we have this first series of serious mental illness and evidence-based practices. This is specifically for volunteer supporters, so more of a lay audience, but I think it has really useful information related to basics about schizophrenia, some evidence-based practices, and then part 3, some information about how you can interact with and support people with schizophrenia spectrum disorders. The second series that you see on the screen are specifically for county BH and courts and councils, but goes over a number of information which could be useful for you about schizophrenia spectrum disorders. We also mentioned trauma-informed care, which at its most basic means that you approach people with empathy and humility. We have a lot of materials about taking a trauma-informed approach, a series that you see linked here for county behavioral health, and also a series for volunteer supporters. There is a specific training for county BH on implicit bias in the care process. That could be a really good resource for first responders to view as well and think about how individuals and also agencies and systems can make adaptations to mitigate bias. The last training we wanted to highlight for you is Psychiatric Advanced Directives. And you can learn about more Psychiatric Advanced Directives and best practices in our training, which is, again, linked in the materials. There are a number of ways to connect with us. Joining our listserv, which we mentioned, filling out a technical assistance request. There's a request form specific to data, and then providing information through our feedback form you see there. But there really is no wrong door. So if you have a question or you want to be connected with resources or you want to know where to find information, please email us at info@careact.org. And we look forward to hearing from you. Thank you.